recorded for minute-taking purposes, as well as for posting of the recording of the proceedings on the agency's website. This meeting is also being live-streamed on the Access Health CT website. It is also requested that participants introduce themselves every time they speak. Roll call for attendance. Grant Rader, Chair.
Yes, here.
Sean King.
I'm here.
Thank you. Mark Schaefer. Matthew Brockman. Manish Jutani. Tune Cohen.
I'm on.
Thank you. John Virkola.
I'm here.
Thank you. And Trisha Dave, subject matter expert from Kendrick Insurance Department.
I'm here.
Thank you. We do have a quorum, Mr. Chair.
Great. I understand there's no public comment. Is that correct?
That is correct, Mr. Chair. We did not receive any public comments.
We'll move to the next agenda item, which is the minutes. Can I have a motion to accept the minutes from last meeting in January?
So moved. This is Sean.
Thank you, John. Second?
Second. This is two.
Two. Great. Any comments, edits, changes? If not, could we have a roll call to accept the minutes?
Grant Rader.
Yes.
Sean King.
Yes.
Mark Schaefer. Matthew Brockman.
Yes.
Thank you. Tune Cohen.
Yes.
Manish Jutani. And John Virkola.
Yes.
Thank you. Motion passes.
Okay, and now the real purpose of the meeting, which is to call on Wakely Consulting to give us details on standard health plans for this year, for the next year.
Absolutely.
Oh, wait a minute. Is there something in here? I'm sorry, Kelly. I missed something here. First, we're going to go to Kelly to note the timeline for the plan year 2027.
Thank you, Kelly Cody, Access Health Connecticut. I just wanted to get in front of everyone some of the updates to the timeline and then a few additional comments. So back in January when we met, we were not in receipt of any of the federal guidance from CMS. As of February, we received the notice of benefit and premium parameters. Boy, that's a mouthful, sorry. And then following that, we received the actuarial value calculator, which is, in addition to getting guidance from CMS, is the crux of what we do here today. So one thing that I wanted to point out to everyone is generally we have this information November, December. So we obviously have a very short amount of time to really get through what we need to do for this upcoming plan year. So with that said, we did make some formatting changes to this meeting to help accelerate some of the conversations. Generally, what we do is Wakely and the issuers all run the plans to see where they fall within the actuarial value calculator, if they pass or fail. And at that point, we display that information to this group so that we may talk about what we think we want to do for plan changes. To help accelerate some of those conversations, what we have done is that pre-work has been done, but additionally, we have also included where we could plan options to have open discussions with this group. This year is going to be a very challenging year. Every standard plan that is offered through Access Health Connecticut will need some sort of plan adjustment. So I know that this is my, I think, 5th or 6th plan year, and we've never had this amount of change or impact to the plans. So that is why we thought that it might be helpful to come with options, and then we can discuss further. And if there are additional options we want to take a look at, we can. We're trying to stay on schedule so that the certification process may start on June 1st. So the next board of directors meeting is scheduled for April 16th. So with that said, we have scheduled weekly meetings. There is one scheduled for the 25th of March and then the 1st of April. If we need additional time, I'll schedule additional meetings, but at this point, just kind of leaving it at that. So I wanted to say, with all that said, I really appreciate everyone's flexibility on the committee. I know that there was a lot of back and forth with trying to schedule dates. I appreciate everyone's patience as we were getting through that. And I would also like to give a round of applause to both Wakely and the issuers for all of their collaboration throughout this process. We really did a lot of work in a very short period of time. Generally, we're doing this over a couple month period. So we essentially started this process on February 25th or 26th. So thank you very much. And, you know, I also would like to say to them, thank you for your patience and flexibility as well. So with that said, we can move on to the next slide if nobody has any questions. Okay, I'm going to hand it over to Ksenia.
Thanks, Kelly. Hi, everyone. It's great to be here with you, and we'll walk through the proposed 2027 standard plan changes. So really quickly, right, we'll talk about the regulatory changes that spur the need to update our benefit designs, the federal AV calculator changes, and then interim results, and then proposed 2027 plans. Next slide, please. So before we dive in, this is probably a familiar information to you all, but just as a quick recap, right? What guides our decision-making process when we look at the standard plan designs and the necessary changes from year to year? So the first and foremost is, of course, the notice of benefit and payment notice that came out last month. It is still in the public comment period and will be finalized sometime over the next few months. The NBPP drives the key parameters of the plan designs, and specifically the maximum out-of-pocket allowed amount for all plans, as well as the silver cost-sharing reduction plan variants. So that really dictates, right, what adjustments are needed to those specific cost-sharing parameters. Along with that, we have an updated federal actual value calculator, right, which is just an Excel tool that measures proportion of total allowed costs that will be paid by the plan as opposed to by the consumer. Every year, CMS makes updates to the actual value calculator to account for additional trend or changes in the underlying population that they project for the next benefit year. And so that necessitates changes in the plan designs as well in order to comply with the de minimis ranges of the allowed actual values. The third item that is still not known to us at this time is the IRS regulation that defines the minimum deductible amount and then the maximum MOOP for the high deductible health plans such that they are eligible for health savings account. We'll talk about what those numbers look like for 26, but again, we're waiting for the final values for 27 benefit year. And then as Kelly mentioned, right, the last piece of the puzzle is to ensure that there is alignment in assumptions that go into some of the blending and calculating your blended amounts of cost sharing by certain service categories that go into the actual value calculator between what the state assesses and then what the issuers use when they run the calculator. So there's a little bit of uncertainty and leeway in those amounts. Next slide, please. Okay, so changes in 2027 regulations. So as I mentioned, right, the NBPP has increased the maximum out-of-pocket amount from $10,600, that was the maximum in 26, to $12,000 in 2027. But the cost sharing silver plan variations, those amounts also increased, and you can see those highlighted in the top box there. So they're 4,000 for an individual for 94 and 87 CSR AV plans, and then 9,600 for the 73 CSR. For family, of course, those amounts are double. For the high deductible, minimum deductible and maximum move amounts, again, for 2026, those were 1,700 and 8,500 respectively. Those likely will increase again in 2027. Slide, please. Just a quick flag that the state premium and CSR wrap programs are not expected to change at this time for 2027 benefit year. The cost sharing reduction benefits that will be provided to eligible members will be provided relative to the updated 2027 CSR plan variants. But overall, the program does not affect the actual values that we'll be discussing in the following slides. Okay. So a couple of notes about changes to the EV calculator in 2027. Some exciting actuarial facts here. So typically the underlying base data that is used to develop the calculator is moved up every year. So for 2027, the experience that's used to develop the claim costs, right, and the tables underlying the calculator are now from 2023 through 21 through 2023, apologies. Individual and small group markets are combined. Was an additional year of trend added, and as you can see, the trends are higher in the latest calculator, 6.7 for medical costs and nearly 11% for pharmacy, which is generally consistent with national ACA markets and how costs have been evolving. And then finally, the demographics were also adjusted to reflect the anticipated composition of the market in 27. Next slide, please. So this slide really summarizes why there is a need to make updates to the plan design features. So to walk you quickly through what we're looking at here. So the second line in each of the tables, the 2027 AV ranges represents the allowable range that a particular plan metal tier actual value has to fall within that range, right? So for example, the gold AV has to be between 78 and 82%. If we look at our 26 AVs that were run in the 2026 AV calculator, the range of actual values that were generated by the issuers is summarized in that third line. And you can see that they're all in compliance with the de minimis ranges, allowable ranges. However, if we run those same 26 plan designs in the 27 AV calculator, so that's the last line there highlighted in red, you can see that every single plan actual value, and that's just using kind of standard Wakely assumptions with regard to some of the blending of the cost sharing, they're all outside of the de minimis allowable ranges. And so we have to make changes for that reason. Okay, so now we're going to dive into the proposed designs. A couple of quick notes before we start looking at the various parameters is that the federal AV calculator is, a pretty blunt tool. It specifies cost sharing for major service categories, but it does not do it in a very granular detail. And so the standard plan designs do provide additional information, right, and specify cost sharing for these additional services that you see on the slide that are not necessarily explicitly modeled in the AV calculator. So just keep that in mind. In the next slide, please. Additionally, out-of-network cost sharing is not part of the AV calculator, so that does not affect the values. We're going to show you deductibles and MOOP limits that are all for a single member, and then family values at generally twice those amounts. Preventative care has to be covered at no cost sharing in all plans. And then the other key piece of compliance, right, when we develop these plan designs is to ensure that the cost sharing for mental health services complies with the mental health parity regulation. So there is an adjustment, or that's a key consideration when issuers test their plans, and then when we design the benefit designs. We are assuming that the silver loading will persist in 2027 unless something changes in the final NBPP. And then, yeah, all plans assume embedded deductible approach rather than aggregate. So let's start looking at each of the metal tiers and the options. So hopefully you can see there's a lot of information on the slide here. But to walk you through what we are looking at, so the second column, the 2026 gold plan design, so again, all of these are gold plans, is what the current standard gold plan is in 2026. You can see that at the bottom there, we have the 26 ADC result, again, showing that it's in compliance with 26 AV calculator. The 27 AV result, 85.3%, again, is if we take that same exact design and run it through 2780 calculator, and it's out of compliance, right? So in order for us to bring down the actual value within the allowable range, the three options are proposed. The changes in the specific cost sharing amounts are highlighted in red. So you can see it affects quite a few service categories, and we are generally increasing, right, all of those copays, as well as the deductible and out-of-pocket maximum. There's slight variations in those three options with regard to how much those copays are increasing in which categories. So again, there's unlimited number of ways to change the benefit design. So we're, I think, seeking input on the potential options. The last line in the table gives you a very rough indication of how these benefit design changes would affect the paid costs. Again, of course, we cannot speak to the exact way the issuers would price these benefits, as they would have their own assumptions, right, around the utilization and a number of pricing variables affecting the final paid costs. But what we've done is we ran our own internal pricing model and ran the 4 benefit designs on this slide. These are all on 2026 cost level. So just keep that in mind. And the cost differences represent, again, the change in the paid PMPM amounts as a result of changing only the benefit design. So you can see that ranges anywhere from $50 to $80 roughly. Okay. Any questions on the gold plans? Maybe we'll move on. Okay. Let's keep going then. So for the silver plan, this is our standard 70% actual value silver plan. A very similar story here, that 2026 designs, of course, out of compliance with the de minimis. And so the changes that are proposed in the 3 options are, again, highlighted in red. I will note that as it currently stands, options 2 and 3 are resulting in one of the, or at least one of the issuers to be out of compliance when they apply their own assumptions and run these designs through the actual value calculators. So there's a little bit more work to be done to ensure that all issuers are in compliance, both from a de minimis standpoint and also mental health parity.
Can I, sorry, I got a question going back, but can I just clarify, since this is on these like why why are we looking at non-compliant, or is there some change you all are gonna make before the next meeting that brings those into compliance? I guess I would,
We ran out of time in making them compliant. Yeah, so there's just a little bit back and forth. So there's a little bit more work to be done. We just wanted to share that, you know, we've tried several options and we're still working through it. Good question. Okay, and maybe we'll go to the next slide. And we'll take a look at the 73 silver CSR variant. This plan is even more difficult because the de minimis range is so narrow. It's only a 1-point difference that the plan has to fall in. And again, both issuers' internal calculations also have to meet that range. So unfortunately, we're still, again, working through
it.
to get
Okay.
to the compliant option there.
Whoa.
Yeah.
Is it safe to say the non-compliance is because it's too high, not because it's too low?
It's actually the other way around, unfortunately. So some of the assumptions that issuers are making internally are causing the AV to be too low.
Oh, it is.
So-
Okay, that's it. That's what I was wondering, because in their last slide, option 2, you would put in a higher out-of-pocket max, and yet, and it seemed to be a less generous plan, and yet it was non-compliant. And I wondered, okay, it's non-compliant because it's too low, not because it's too high.
And actually it varies. Sorry, I was speaking specifically around the 73 variant, but for the 70% variant, I think it actually might have been too high. So
it still is too high, even though
changes.
it seems to be less generous, and yet, well, chiropractor is 80
Yeah.
instead of 50, but it just surprises me that you raised the out of pocket to 12,000, and you raised the medical deductible, those are two of the biggest drivers. So it's very surprising to me that raising those made it non-compliant. You know, in other words, made it too high.
It's a great question. Again, just to maybe not to get into down the rabbit hole, but you know, when Wakely ran these options, they are compliant with our assumptions with regard to what cost sharing applies to what services. Issuers have their own assumptions in regard to that, and that's what's causing the non-compliance.
Okay, all right, but you're still working on it, so you'll give us
Yes,
an option that falls in line
that's right.
eventually.
Eventually. We're working on it. All right, and maybe we go to 87 plan. So 87 plan, there's only a couple of changes that are needed. This was an easier task, and we're in compliance. All issues are. So I think we are in a good spot for this particular plan. And for 94 AV CSR, similarly, there's two options. One that has a higher increase, significantly higher increase on the out-of-pocket maximum, versus a second option that raises more of the copays for various services, but keeps that out-of-pocket a little bit lower. Both have a similar impact on the paid costs in 2026. So you can see those changes. And then we have a bronze non-HSA eligible plan. You can see again the changes that are needed to bring these plans into compliance. Generally for bronze plans, the allowable AV range is so wide, that it's much easier to get these plans to comply. So you can see that the resulting 27 AVs are definitely on the higher end of the de minimis, and so those would result in generally, slightly higher premiums in the bronze plans, given the potential, for a very low AV range, and we'll take a look at those plans here shortly. And then if we go to the HSA eligible bronze high deductible plans, no changes essentially was needed to this plan because they are, you know, highly coinsurance and deductible based plans. They're still in compliance. Actually, maybe just the change is not highlighted because it was slightly out of compliance, right? So we did change. Oh, out of pocket is not highlighted. Gotcha.
Yeah.
So I think again that plan is at the very top of the de minimis, nearly 65% AV. And so to then introduce a bronze plan that would result in a lower premium relative to those other two bronze options, these two lean bronze plan options target a much lower AV, right? So you can see 60 or 59 to 58 AV. I guess it's 59 pretty much. And you can see that the amounts, the out-of-pocket maximum is at the very top there. But it does come with, you know, a significantly lower paid costs, $75 to $92 PMPM, which would translate into relatively a lower premium relative to the other bronze plan options.
And I just wanted to interject on this one. This was something that we thought we would want to present to the group as a possible addition to maybe the standard plan offerings if the committee is interested, and really bridging the cost difference between when a enrollee goes from a catastrophic plan to a bronze plan. They may be looking for that option. They may be a very healthy individual and they just want coverage. They're no longer eligible for the catastrophic plan. This could potentially be a good offering for that member, should they just be looking for a low cost option.
And also, hi, this is Susan, just to add to that. As you know, HR 1 changed and made all bronze and catastrophic plans eligible to be linked to an HSA, but the catastrophic plans cannot have APTC applied. So I think this is why, you know, if this is something the committee's interested in, this could be a way for a consumer to still, if they're eligible, apply APTC to their plan premium, but be in a plan with hopefully lower, you know, it may have higher cost sharing that they could pair with an HSA, but then have lower premium overall.
I think this is a smart idea to put forth.
Yeah, because our bronze non-HSA plan, you know, our not high deductible health plan bronze has gotten very rich over the years, and it's right up at the top of the just under 65, which makes the premium higher, you know, makes the benefits richer, but makes the premium higher. So you're kind of trying to balance all that.
That brings us to the end of the presentation. If there are any other questions we can answer.
Yeah. On the question of the bronze plans, it's kind of curious who's buying which plans. Are people buying the bronze plans because they get the premium tax credit and therefore they don't have any expense, or are they buying it because their income is so high that they're not eligible for premium tax credits and therefore they're searching for the cheapest plan of all? Because it seems like those are two very, very different groups, and one might want a very rich bronze plan if they're not paying for it, and the other one might want a very, very parsimonious bronze plan because they are paying for it and they want a lower premium. So I'd be curious to know what percentage of each one of these plans in today's you know, current situation, what percentage of them are in the premium tax credit group, and which one of them are in the no premium tax credit? What percentage buy the bronze plan because they're not getting any tax credit.
I can get
So
that
maybe
We
it's
can
information.
look
future.
at that, yeah.
Yeah.
We can look at that, and then also for this year, for 2026, we have the temporary premium assistance program from the state. So those folks who are over 400 but up to 500 are eligible for the temporary premium assistance. So there is some help for them as well. But we can look at that for the next meeting, Grant, to really look. And I think we did see an increase. We didn't see, you know, a huge movement in the enrollment for 2026 of people changing plan tiers. But for the people that did, I think we did see the growth in the bronze, which is what we had, as you would expect, before ARPA went in 2020. You know, we had gotten to a point in 2020 and probably early 2021 where we were almost like 50-50 of silver versus bronze versus, you know, when we started, it was different. So I think the mix has shifted, but yeah, that's a really good point, Grant. So we can definitely get more data for the committee to think
Well,
about.
certainly that low cost bronze plan would be
Right.
more attractive to the non to the non premium tax credit group, you know, who are just interested in some kind of a top end to what their cost could be in
Right,
medical.
and they may be someone who has money that they've had in an HSA, you know, from another job that they've rolled over. So they have that, you know, HSA funding available for their cost sharing as well.
Yeah. Sean, did you have a question?
I did. Thanks, Mr. Chair. I noticed that all of these changes in the plan designs that are intended to bring the AVs down also seem to come with a reduction in the PMPM premiums. And so I'm kind of wondering if you can give us some insights into what's creating that dynamic.
Yeah, certainly. And again, it's an approximate indicator of the movement, right? Where if we run 2026 benefit designs and the proposed 2027 modified benefit designs through the same pricing model, right? So it's just a lower cost sharing. Still, it increases the cost sharing for the member, of course, right? But it also reduces the pay costs for the issuer from the AV perspective. So again, it's difficult to comment on the 2027 pricing because there will be, right, additional year of trends and other morbidity assumptions and et cetera. So please use those as an approximate indicator of the directionality of those changes.
My take on that, Sean, was that we were butting up very close to the top end of the de minimis values in the previous year. I mean, every time we were like 0.1% below it. And I think this time we are a little further away, and I think that's creating a PMPM that's reduced a little bit. One of the things is that we're rounding our out-of-pocket maximums and our combined medical and prescription drug deductibles to the nearest 500 very often. And by rounding that off, it lowers the AVC results a little bit, you know, drops it a little bit, and that creates a PMPM value that's also negative. I suppose we could refine it a little more and make our out-of-pocket rounded to the nearest 250 or something like that, and maybe, you know, get the PMPM closer to zero, change closer to zero.
Yeah, I
That's
guess
just,
yeah,
that's just a guess. Yeah.
I was that, so that all helps, and I'm not an expert on the math piece of it that goes behind all of these calculations, but you know, I was curious if it was sort of a function of just the extremes in the trends as the trends continue to climb, if that is more of a primary factor in this sort of this dynamic where we increase the cost sharing on all of these items, but somehow the offset in the PMPM is even that more extreme when we do that. Is that fair to say, or is that poorly articulated? That's kind of what my question was trying to aim at.
Mm-hmm.
That,
It was
that's certainly
consistently
possible.
negative throughout all the plans. It was negative.
Okay, thank you.
I mean, my sense is it's a side effect of where the federal administration, right? We have pushed over the years to keep out of pocket low, driving up premium, and the federal government is pushing us now in the opposite direction of keeping premium low at the expense of higher out of pocket, or increasing out of pocket, which pushes premium low. I think it's the federal government through the AV calculator is pushing us in a different direction that we have historically pushed in Connecticut.
Yeah, there were significant changes, sorry, in the calculator this year, as you can see with the AVs.
What is the source for the PMPM as opposed to the source for the rest of the actuarial calculator is percentage of premium, but is it a national premium? I mean, the PMPM, is that a national estimate?
Yeah, so let me again summarize really quickly how that was calculated. So we took Wakely internal pricing tool, right, which is a different model from the AV calculator.
Yeah.
We calibrated it to 2026 average allowed cost in Connecticut. So using a blended allowed cost from the issuers. And then we ran the benefit designs, so 26 and then the proposed 27 through that model, and obtained, right, paid PMPMs, compared those relative to the 26 benefit design PMPM. And so that's how we arrived at those costs. So they're not premium amounts, right? They're just the paid cost differences. And again, they're still on 26 allowed basis. So just keep that in mind. If that helps.
I do think for the next meeting, it would be helpful to understand the intersection between the APC, whatever, the premium cost sharing reduction and the plans, because I think that's also an, it's complicated for us to totally figure out because we don't actually have cost, but to the extent we can incorporate that into our thinking, I think is helpful.
Yes, have these been run by the plans to see if they're compliant with the plan? As well as with the national AVC?
That's what caused some of the non-compliant labeling.
Oh,
that
okay,
we
it did
saw.
go through.
Yeah,
All right.
exactly. Yes, that's
All
the
right.
issue right now.
Thank you.
Yep.
Right. So they are compliant with the national AVC, but they're not compliant with one or more of the plans here in the
Correct.
state. Got it.
Some of them, yeah, not all.
Yeah.
Yeah, and Grant, the carriers, this is all the work Kelly was referring to that we've been doing over the last few weeks with Wakely. They've been running testing and all these different options Wakely presented, not only for AV, but also mental health parity, because you've
Yeah,
got
there's
to need
parity
both.
involved too. We
And
run
it gets
into that.
very specific because then
Yeah.
carriers are using their own claims experience. So that's where you can have variation.
Right. Right. Well, I think everybody should look at these plans and come up with their favorite option and which ones they really reject. I'm still kind of curious, back with the gold plan, why option 2 seemed to have a higher, seems to be higher in the medical deduction. Well, no, wait a minute. No, that was, let's see, what was it? No, that one, I'm sorry, it must be option 2 on the silver, the regular silver, standard silver. Option 2 on that. There we go. It's higher on the medical deductible and it's higher on the out of pocket. Admittedly, it didn't try to change some of the copays, but it's non-compliant, which means it's probably higher on the, I think you said it was higher on the AVC. And that surprises me since it was, the medical deductible and the out of pocket are the biggest drivers of the sort of percentage, the AVC percentage. They seem to
Yeah,
have
it
more
was,
effect than anything else.
it was a issuer specific compliance.
Yeah.
So yeah.
Well, keep working on those, but you know, the option 1 might be the way we have to go anyways. With a chiropractor of $80 seemed to be the, and much, well, all the benefits categories have higher copays. Is essentially how it's working. So the choice is in option 1, you change the copays, make them higher. In option 2 and 3, you change the deductible and the out of pocket. So it just depends on which group of people you're sort of affecting.
Yeah, and Grant, this is Kelly. Just one other thing that I want to comment on, so people don't lose sight of it. While the deductibles may be increasing, especially on the silver plan, there are a lot of services that are pre-deductible. So I just want to make sure that everybody keeps that in mind.
We try very
I
hard
know.
to have some things that are pre-deductible, something to give back to the,
Yeah.
And at least also in the silver plans, there's a separate prescription drug deductible that's very low. You know,
absolutely.
250 versus, yeah. So it makes prescription drugs more accessible too.
Mhm. Well, we like to preserve that at all costs, even if it does raise the copay.
Sure. So do we want to start at the gold plan and just kind of work our way down to see what the group likes and doesn't like, and then maybe we can
Sure.
formulate.
Yeah.
Okay.
That'd be great. Here, the options, it just, I'll tell you what I don't like is option 2 with the radiology being after deductible. I hope we don't need to do that. Like I said, the more that we make before the deductible, the better, as far as, and the more attractive it is to my mind. I hope others feel that way.
I want to give you a little bit of background on this gold plan. Our standard gold plan probably has the least amount of enrollment when it comes to the gold plans. And mainly that is because this plan is the most expensive plan on the exchange. So I want to throw that out there. So I understand that you want to preserve the benefits, but also keep those sets.
Yeah, is there a non-standard gold plan out there competing with it?
Each carrier does offer
Yeah.
non-standard gold plans. Yes.
Yeah.
And they have, you know, different benefits and lower premium.
Yes.
Lower premium, but they're still gold.
Correct.
Any other comments? I mean, what seems to be the most attractive? I mean, you said that this standard plan, because the premium so high, is the least popular. What are the benefits that the others non-standard goals keep, and which ones do they sort of jettison?
I'm shuffling papers. I think one of the items is that the obviously the plan is far richer. From the 26 plan year, the standard gold plan average AV is about 81.30, let's just say. we'll just call it 81. The non-standard plans, they fluctuate between 78 and 79. So, you can see the difference in the AV there. The most notable difference is probably, they have slightly higher, deductibles. I'm trying to look at the out-of-pocket maximum. Yeah, the out-of-pocket maximum as well is slightly higher than what the standard plan is. And then as far as plan design is concerned, they're relatively the same. There are some benefit outliers when it comes to the pharmacy. Most of the other plans are, it's on the non-preferred brand drugs, where those are usually at a co-insurance level.
The tier 3?
Yeah, the tier 3. It's all co-insurance, and most of them, the deductible does not apply. Whereas on our standard plan, it's a flat $60. And then our the 4 tier actually has the drug deductible, but it has a maximum up to $100, where some of the other plans, their maximum is a little bit higher, or actually, somewhere between 750 and 1,000. So there's really no benefit outliers, like anything other than those that kind of stand out to me.
Okay. I think what's happening is people go for the price and they don't really read the fine details and realize just how much better our plan is.
Yes, the plan is very rich. Yes.
But that tier 4 drug can be a killer if you don't have something maxing it out. I mean, drugs can be so expensive, 20% can break the bank.
Absolutely.
Okay.
Grant, what's the history behind the not having any copay on home healthcare services?
Oh, home health. I don't know. We were just, what does it say there? Zero copay. I have no idea why that's in there. I didn't realize we had anything with no copay. Home health care services up to 100 per day. That's new to me. I'm not even sure we had home health care as a row in earlier years.
We'll have to look at that. Kelly, do you remember? I don't think there's any state mandate or anything tied
No.
to home health care services.
No, and actually that was a good call out, because that actually is one of the benefits that is an outlier from any of the other non-standard plans. All of them have a minimum of 10% coinsurance.
Wow.
So, and I think what we did, I don't think in the past, when we've provided this view, I believe it only included the items that actually impacted the actuarial value calculator. This year, I think we've added the additional benefits that, while they may not have impact to the overall AV, they could have impact to the overall cost of the plan. Yes.
Yeah, we weren't aware of home health care services, and I think it's because it was not part of the AVC before. It's not part
And
of
I
it
don't
now.
know, too, sorry, Grant, we'll have to look at the benchmark plan. I don't recall what the number is in the benchmark plan either.
So I don't imagine there's enough utilization to materially impact how high you have to go on other areas by introducing cost share on home health. I mean, it's more of an over 65 benefit, but just since it's on there, I figured I'd ask.
Mm-hmm.
You may want to go back and check the state mandate. That could be a potential.
Let's go to the silver. Is it listed on the silver plan, and is it also zero copay? Yeah, it's always yeah. So interesting.
we can take away, just for the sake of time, I can take that as a takeaway to look at the benchmark plan.
Yeah,
and the
make it
state mandate
10% or
to make
whatever
sure.
it is whatever qualifies for the benchmark plan. um, should be used here too.
Okay.
Okay. So what I heard about the gold plan, if we go back to that, that maybe option 3 seems to be more attractive than option 1 in terms of what to do. In other words, raise the deductible, raise the out of pocket, even on the gold plan, because that seems to be what the purchasers are putting their choice on as a non-standard plan. But we could make it the standard plan as well.
I'm okay with that.
Well, I mean, on the other hand, to be honest with you, what do we care whether it's a silver plan or a standard plan or a non-standard plan? There's no, because they offer it, there's no real difference to the consumer whether it's called standard or not, is there? I mean, they get the tax. Well, not many.
Yeah, no, it
Right.
does, that doesn't matter to the consumer. The point of the, part of the point of the standard plans is to give consumers an apples to apple comparison that where
Right.
the benefit design is the same across all carriers. And then they're looking at premium provider network, excuse me, and the prescription drug formulary as the differentiators. So, and then giving the carriers the options to offer the non-standard plans so that there's, you know, flexibility to come up with other creative options.
No, that's great. In fact, if we keep, well, let's look at the percentages. Just like I asked before, if we could see what percentage of the consumers buy our standard plan versus what percentage, go for a non-standard plan that's got a cheaper premium to it. But actually offering this high value one, apparently the carriers are going to offer lower premium gold plans as well. So there's choice. The consumer has more choice. As long as some group wants this higher premium plan, we probably should offer it to them. With the 80% or 81% AVC calculation, as opposed to the 78 or 79% one that the carriers might offer. Anyways. So let's get a percentage on that to see what group is purchasing which type of gold plan. And the if they do get a tax credit, it's the same regardless of which gold plan they buy.
Correct.
Yeah,
Correct.
it's only based on their income. Yeah,
It's
Correct.
based on their income and second lowest silver. And then
Yeah.
obviously it wouldn't come in with the gold because the premium's higher. But at bronze, you can't have a tax credit larger than your premium.
You don't get money back.
You
Yeah,
get mine
yeah.
back.
Okay. So we have thought here. I mean, the main question always arises: do we actually raise the deductible and out of pocket, or do we, raise the copays and change some of the first dollar benefits instead? And that's the question every year. So that's going to be the question this year too.
Can you
Okay, so
remind
but
us?
What's that?
I'm just wondering on your point, maybe you covered this in the previous slides. Exactly which services are the deductible does not apply?
Yeah, that's
they're all noted actually on this. So if it says after deductible, the deductible applies. If it's left
Okay.
blank, it means the deductible does not apply.
So here, even primary care, preventive care, your annual wellness visit or what have you, the deductible applies to your annual well visit, for example. There's not an exemption.
Not
No.
the preventative has no cost sharing, Mark. That's, under the ACA. But that would be other primary care if you were sick and went in to see your PCP, not
I
for your annual physical. That would be what the cost sharing is.
Yeah, what you're paying for with the gold plan is that many services are not subject to the deductible. That's you're paying for it through the premium ahead of time, but they're expensive plans. With the bronze plans, everything is after the deductible, apparently.
I think we managed to squeeze some services in pre-deductible.
Okay, that's good. It's nice that there are some. Yeah. With the silver plans, it's sort of a mix. Some are, some aren't.
Yeah, again, with the silver plans, there's a lot of services that are pre-deductible.
Yeah, we tried to
Yes.
provide some that were before the deductible, because the deductible, I mean, it's $5,000 before you get your first benefit. It's kind of rough.
Can we go back to the goal plan again?
Yeah, okay.
Can Weekly go back and run maybe a scenarios where you have a $2,000 deductible versus a $3,000? Because going from a 1,200 to all the way to 3,000, that's a drastic change. So it might be good to have a 2,000 as a consideration as well.
I was wondering about the same thing. Is there a consensus that is there a consensus grant that you said the advanced radiology $75 after deductible seems highly unattractive? So I'm just wondering if
I think it is unattractive. So many things to use a PET scan now or an MRI that I mean, people might find that to be unfair to make that the only thing that's after the deductible as opposed to all these other services. So yeah, no, I would rather take option 2 to be a $2,000 medical deductible and $75 advanced radiology and see where that falls. If it
Noted.
Yeah, play with the chiropractor and the other copays to make it compatible, compliant.
Yeah, and I think what we'll do too is just to make it a little bit make it helpful for the group, we'll try to highlight which items have impact to the AV and which ones don't, or maybe we do which ones don't. But obviously those have impact to the premium.
Yeah.
The overall premium.
Okay, well, we're at the end of our hour now. Should we study all of these and come back next week and possibly make some choices?
How quickly will you have the silver plan, a set of silver plan options that are compliant?
Well, I think the goal is after this call, we will probably regroup with Wakely and the issuers to come up with some common ground and figure out how we can get to compliance for everyone.
Mm-hmm.
So the intent is to hopefully have that done and ready for next week.
Mm-hmm.
Okay, great. So, Kelly, do you have some last words here?
Not really, other than I guess we'll see you all next week. Question if we actually have information available prior to the meeting. I'm not sure if it's a normal protocol, but based on the limited time frame that we have,
send it out.
Send it out. Okay. All right.
Send it out. Yeah, and take a look at it. Yeah, no, it would be nice if we saw those silver plan in their compliant for. I don't imagine they need to be changed that much, just a little bit of tweaking to make them compliant.
Okay.
And that'd be good to look at ahead of time, even in anticipation of Wednesday morning's meeting.
Absolutely. If available, it will be sent out.
Okay.
Excellent.
Thank you so much, Wakely, for all this analysis so quickly. I know that time has been short.
There is no adjournment slide, Mr.
Oh,
Chair,
okay.
so
No
this is
adjournment
our
slide.
last slide.
So could I have a motion to adjourn for this morning?
So moved.
Okay, seconded?
Second.
Sean.
Oh, okay, sure. Motion, can you do a roll call?
Yes, Mr. Chair. Grant Brader,
Yes.
Sean King,
Yes.
Mark Schaefer,
Yes.
Matthew Brockman,
Yes.
John Cohen,
Yes.
Manisha Sultani, and John Virkola.
Yes.
Thank you.
Thank you very much. We are adjourned. And we'll see you
Thank
next
you.
week.
All right. Bye.
Thanks,
Bye, Brad.
everybody.